Jake. I just wanted to put this together quickly, just as a sort of things that I wish that I knew before I started medical school. Because I guess you look back, coming towards the end of medical school for me now, and I sort of wish, well, oh, that would have made my life a bit easier. Maybe this will help you guys, maybe it won't. But here we go anyway. So, firstly, I was sort of always thinking to myself as I went through, how could I possibly ever know enough content to be an adequate doctor? It sort of played on my mind a little bit. So just firstly to sort of normalize that, like, you will feel totally inadequate at times, maybe all the way through, until personally right at the end of medical school you start realizing a few things, like interns and junior doctors don't actually know everything, and it's impossible to know everything. Although I guess doctors, we like to put medical students and doctors, we like to sort of portray for ourselves and for our patients that we know more than we do, which, in some aspects is okay, but I think that can come across to juniors sometimes and junior medical students that I'm not adequate in myself, but just know that you will eventually get there. Everything comes together. Believe in the system and the fact that you go over spiral learning. You go over things again and again and again, and it might seem like complete rubbish, and you might not understand anything the first time, but I promise you will get there. Secondly, so you only need to know enough to be safe, especially to be a junior doctor. So you're just not going to be a consultant at every topic. It's just not possible, is it? So I guess that realization comes towards the end of medical school as well. Like, you really only need to know the key things to be safe, whether that's picking up that someone has appendicitis and not gastroenteritis. So like knowing the differences and how to examine them and what tests to do and what to look at, and it's stuff that you will get towards the end. So just trust in yourself and the system a bit, and like following on from that, so the whole system is a team. Like in medicine, you're rarely ever is it all just going to be down to you. So if you make a decision when you're a junior doctor, like, the pharmacist is probably, if you write a prescription, the nurse is going to look at it, maybe the pharmacist is going to look at it, and it's not just going to be down to you. Maybe two nurses will administer it, depending what it is, and they have to check it. So, there's always going to be a senior there, like 99% of the time, there's going to be a senior there, especially for the serious stuff. So just sort of, don't worry, I guess, is my first point. And then secondly, how to PBL. So I sort of, again, this will be very personal to each of you, but I sort of battled away with PBL throughout medical school. So I just wanted to, I guess, give you a few tips and take it as you will. So firstly, I always felt like I needed to include everything and try and make perfect notes and all this sort of thing. It's just not possible. If you're anything like me, I also am really messy with making my notes and stuff, so it sort of stressed me out a bit. But I think in hindsight, what I would do is sort of, and I did this towards the end, I'd sort of just know where you've got your basic resources from. So just go and pick a resource and read it. Don't sort of over-resource yourself trying to read Guyton for the physiology part and then the whole chapter of your Moore's clinical anatomy for the anatomy part and blah, blah. Just, okay, like maybe take bits from different areas, but just pick a resource. If you can, get one resource that covers a PBL question or a PBL section. Just knock it out from one resource because it will make more sense. And just towards the end, I was just sort of knowing where I had read my basic information and then just go straight to writing sort of summary notes if possible. And I would even sometimes paste in the textbook stuff into a document so I can Command F and search through and feel like I've got all my information there and go through and read and highlight if I want to. But then don't try and type out a perfect version of that yourself. You're not creating a textbook. Just have those resources there and then go, okay, I'm going to write my summary notes. They're not going to be perfect. They're not going to cover everything, but write down the things that you want to remember. Because basically, come the end of the day, you're going to get round to exams. And if you go back and you've got 80 pages there and that's all you've done, then it's not going to be useful. You won't have enough time. But if you've got that stuff off to one side and then you've got 1 or 2 pages of stuff which is succinct and key facts, then at least that's something that you can at least arm yourself with going into exams and things. And so on the topic of PBL and resources, Toronto Notes I cannot give enough sort of praise to. You can get a PDF of it and or find it from, I don't know, online, or maybe you could buy it, but usually there's copies of things circulating, but do as you will. But so Toronto Notes, see if I have it here actually. I should have probably thought about this preparing this, but anyway, Toronto Notes will basically go from start to finish through a topic, give you a little bit of pathophys, a little bit of background on what you need to know, very clearly outlined definitions, and then it just nails all the clinical stuff very succinctly. So check that out, definitely. Oxford Handbook of Clinical Medicine, the cheese and onion, as the pommies call it. It's like a green and yellow book. That is also excellent. I carried that with me on the wards and things like that. It's a great sort of memory aid, and it nails the clinical basics as well. So those two are key. I think clinical key is another thing to know about. So just in terms of accessing things from home. Let's just go, if you go UON library, if you go to the library page like this, basically you can get everything through here. So let's go, clinical key. So there's two ways you can go about this actually, but basically searching anything in the library thing from home, connect to resource, log in, and you will be able to access clinical key from home. Click on books down there, and then type whatever the heck you want. If you wanted Tally and O'Connor's Guide to Physical Examination, there it is. If you wanted something about surgery, then I'm sure there's something there as well. It's a good way to get textbooks from home. The other way to sort of shortcut is to go easy proxy. You can see the URL up there, and then it shows you literally every membership. So it will have clinical key on there that the uni has. It should have clinical key on there. Anyway, we'll have up to date, which will give you basically any topic, evidence-based, that you can think of. I've saved all the links up here as well, actually. So that will be a little bit like very in-depth, might help for some complex PBL questions, but I wouldn't spend too much time on up to date. Another key one that you really, really need to know about is ETG. So why didn't they tell us about this at the start of medical school, right? So on the wards, you will only use basically ETG to tell you what drugs to use. That is the Australian guidelines. Okay, so that link is completely wrong from there. So that doesn't usually happen. I think the uni's been having some problems with it. I'll click on my link. Yeah, so if you wanted pneumonia guideline drugs, this is the gold standard in our hospitals, what treatment people should be on. It won't give you any sort of, no pathophysiology, usually, nothing like, it sometimes gives you diagnostic stuff, which is useful, but it's like basically purely clinical and drug stuff. But any sort of drug regimens, or if you're like, oh, what treatment should people get for pneumonia? Well, so it gives a bit on the etiology actually. But so ETG, always think ETG. what's the treatment for this? Look on ECG. If it's not there, then sure, look elsewhere. But that should be your go-to. So CAP in adults, so community-acquired pneumonia in adults. Empirical therapy, so low severity. Approach to management, blah, 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 blah. And then it tells you what they should be on. And this is literally, all the doctors will, well, a lot of them know it by heart because they've done it a lot, but they will go on here and look, and that is the gold standard. That is what your patient should be on. And it gives you heaps of details. But yes, ECG, very important. What else did I say about resources? So, yeah, another one I should mention is AMBOSS, AMBOSS. It does cost about $50 a year for just the textbook version. It is very good, high yield. It's a little bit American. So the problem with resources and things that I found, and a lot of people find, is that are not very many Australian-based resources, which means, you know, our guidelines may differ a bit. AMBOSS is very good for summarizing like the facts about a certain topic. So like pneumonia, you will go bang, pneumonia, what's the top 5 clinical signs of pneumonia? What is the rationale of treatment? What is the blah, blah, blah? And you can use it as your basic, like, quick way to look things up, or it will give you good mnemonics and things, so it's very good. But then, of course, like we said, when it comes to the treatment, you should be looking at ETG for the drug regimens. But it's okay to learn from other resources to get the general idea, because again, like I just said, doctors look it up on the wards, and this is another example of like, how will they ever know everything? Well, you just need to know that ECG exists. But you know what, if you're going to memorize a drug regimen for an exam because you want to, or you think it's relevant, then you know what, do it from ETG, because that's the Australian one. Exam prep. So, yeah, again, very personal, and I think I'm preaching to the choir because you're all good at exams because you've got into this course. But so I'll just give my 2 cents on that one, which would be again back to my tips on PBLs. I wish I just, for each PBL, at the time that I did it, tried to write down a page worth of key facts to memorize for the exam, because that's what it comes down to, doesn't it, really? In reality, I ended up usually trying to go back through all my PBL stuff and create summaries in Stuvac, which is also okay. I think the best ways to go about things are flashcards or summaries, teaching other people, and also practice questions. So the past questions, if you can get them, but also pastmedicine.com. I think it's .com, but anyway, Past Medicine, it's a UK resource, extremely good for multiple choice, and also just teaching you stuff, because it will give you the answer with a sort of evidence-based topic summary underneath the answer, and it explains everything. So AMBOSS and Past Medicine are the only 2 sort of paid resources that I would recommend highly. Anyway, moving on, so physical examination. So that's another thing that I think is, you know, when you come into medical school, it's a bit intimidating, but let's just break it down. There's 4 main categories of examination, really, which is cardio, resp, gastro, neuro. There's other stuff, sure, but these are the basics that you need to know really well. They're basically pick a structure and stick with it. I've put IPPA because that's inspection, palpation, percussion, and auscultation, which stands true for cardio, resp, and gastro. You know, what do you do first? You look at the patient from the end of the bed, and then you proceed to, and you sort of get a basic structure in your head. You look at their hands first, move up from there. What do you do? Pulses, you do your blood pressure, you look at their mouth, you look at their eyes, proceed to the chest, and then you inspect the chest, you feel for the apex beat. Percussion, not so much in cardio. Auscultation, obviously in cardio. In the rest one, all of it's the same except when you get to the chest. Well, most of it's the same until you get to the chest, in terms of the order you do things in. And and then you go anteriorly and posteriorly, don't you? You inspect, you palpate, you feel for expansion if you're doing exams, you percuss, and then you auscultate and you listen for breath sounds. And it's a good structure to sort of have in your head. When it comes to exams, you know what? Just get the exam OSCE criteria and practice that. Practice the hell out of that. Pass your exams. But the key thing that you're trying to get out of this is, eventually being adequate, being competent on the wards. And if you've just got some sort of structure, then you'll go about things a bit better. With neuro, there's a little bit more, isn't there? I've written that down, which looks complicated, but inspection, palpation, tone, power, reflexes, coordination, sensation. So that's literally all I have in my head. Like a little chant, if you will, when I think about neuro exam, upper and lower limbs at least. Inspection, palpation, tone, power, reflexes, coordination, sensation. And then that's pretty much the whole exam. And then you remember stuff underneath that. Cranial nerve exam. Obviously, you've got the numbers of the cranial nerves to just go through to remind you what to do. So it's all about just having a bit of structure. And then finally, the med school paradox. So for me, I felt like you needed to sort of, you'd study cardio in first or second year, and suddenly you're expected to know not just heart failure and MIs, but you also need to suddenly know all these complex arrhythmias and structural heart diseases and all this complex stuff. And it's like, well, why do you need to know everything for this exam? And then later in medical school, so now when I'm getting to the end of it, we sort of reflect on that, and you're like, well, that's okay, but really I should have been focusing on knowing MIs and heart failure really, really well. And the other stuff is just sprinkled on top for exams, but don't stress over it, because as junior doctors, you just need to know how to manage those emergencies and those common things. And then any other extra bits that it's great and it's good for context, but that's what your registrar and your consultant are there for, So I do think it's a bit of a paradox, and I sort of wish someone had told me at the start that, for cardio, the main things are MIs, so heart attacks, and heart failure. And if you know them really, really well, then you're probably going to be all right later down the track. Respiratory, no COPD really, really well, because it's really common. No pneumonia really well, because it's really common. And then, asthma, and there's a couple of others. And then, the fibrotic lung diseases and things like that. Know a tiny bit, but you can look it up, If it's not an emergency, you've got your senior there. You'll be okay. Neuro, no strokes really well. No Parkinson's really well, because it's, reasonably common. There's some slightly complex medical treatments for it. Yeah, just know a structure for those. No seizures pretty well, the emergency management of seizures. And, the other more complex stuff, again, just sprinkle it on top. Gastro, no inflammatory bowel disease, so know your Crohn's and your ulcerative colitis. Know your acute abdomen stuff, so appendicitis and things like that. And then sprinkle the other stuff around it, and it's going to be fine. So anyway, that's my 2 cents for that stuff. Hopefully it's a little bit helpful. Oh, I meant to say as well, for physical examination, so Tally and O'Connor is, I guess, your gold standard, how things are done. You know what? There's a summary at the end of the chapter. Go and have a look at that. That's, it's good to know the explanation behind the different signs, and there's also a book called Mechanisms of Clinical Signs, or you can just Google it to give you more understanding as well, if Tally's not enough for you even. But once you've been through that once, it's not really what you need to know in practice. You just need to have that structure. Geeky Medics on YouTube is awesome. Watch that. And just get good at, like I said before, get good at doing the basic stuff, palpating abdomen and, recognizing when someone has tenderness in a certain area. Get good at auscultation, but don't worry, because you know what, it's probably going to be replaced with bedside echo at some point. But But get good at that. Get good at feeling pulses. What's a normal pulse? Things that seem easy, but you really need to know the normal. But yeah, what else was there? Along with that paradox, I think you'll find as you go through, along with that having to know everything at the start and then just focusing on the key things at the end, you'll also sort of realize that there's a few different ways of going about medicine. There's the GP land way, there's the medical ward way, and there's the surgical ward way. And they're very different. If you get sent to review a patient in medical land or surgical land, or if you see a patient in GP, they're very, very different. But basically, you're going to be moving from knowing the Italian O'Connor or even OSCE physical examination, and you're like trying to remember everything about different diseases. And then you're going to be moving to a focused examination on your actual patients on the ward, a focused history, and then knowing the key things about their management. So I just thought I'd mention about that it's something that you will experience, sort of this changing dynamic in how you apply your medical knowledge as you go through medical school. But just know that in GP land, it's basically a 10 to 15-minute consultation if you're lucky. So they very much, when I say focused examination, that might just be listening to their chest and having a brief look at their vitals. And that might be it in reality in GP land for someone who's got a cough and a cold or whatever, or and you really don't worry about it so much, but it's just something to be aware of. In medical land, you might spend half an hour on a patient and you might do closer to your Italian O'Connor examination and closer to your Italian O'Connor history. And versus in surgical ward land, they will see patients in a couple of minutes, sort of thing. They will go through and bang, bang, bang. Okay, the patient's got tenderness in this area, and they have not been able to eat in 2 days, and they'll just put the basic facts and then move on to their management. And it's just a different way of doing things. And then there's another sort of a little bit unifying way of seeing a patient, which is the A to E approach, which you will learn in 4th and 5th year, which is sort of combining all your physical examinations into a standardized approach, which will be like if you're sent to review a patient on the ward, so you're not admitting them and doing the whole thing, but it's more of like in an emergency situation or when you're reviewing a patient, and that's like going by airway, breathing, doing a little bit of resp stuff, C for circulation, doing some cardio stuff, D for disability, doing some neuro examination stuff, and E for exposure, and you can include some abdo stuff there. So it's just something to be aware of. Anyway, those are the things that I wish I knew. I had a few more topics to go through, but it's going to be too long. Maybe if there's demand, then I can do that as well, but I ramble a lot. So I hope that helps, and yeah, feel free to shoot any questions through to me.